I'm Christine Bridges. I've met a few of you guys, not everyone, but I'm currently a Hospice and Palliative Care Fellow here at U of L 102. My background is actually family medicine, so that is to say that I'm used to internal medicine doctors being smarter than me. So feel free to contribute if you have thoughts or input or questions. This is supposed to be interactive, so please feel free. What we're going to talk about today is a topic that everybody loves to talk about, which is advanced care planning. I picked this kind of background because much like this background, we all hope and expect advanced care planning to be nice and neat and orderly, but sometimes it's a little bit messy. So we're going to do our best to kind of break down some of those challenges and talk about that today, and please feel free to ask questions. Okay. So I have no financial disclosures, sadly, which is pretty rare in the palliative world, but I do think palliative care is very important. So this is just kind of the overview of what we're going to talk about today, just the basic definitions of what advanced care planning is, what documents are available, billing and coding, and then some clinical pearls. So what is advanced care planning? I think a lot of times we think of this as something that may come at the very end of life and be kind of an emergency type situation. And actually advanced care planning is something that can be a lot of different types of communication. Sometimes it involves patients and their lawyers, patients and their families. But in any way that advanced care planning occurs, it's a chance for patients to communicate to those of us who are going to be helping them make healthcare decisions what their healthcare decisions are that they're interested in making. So this is a quote or a statement from the AHPM. They have kind of a consensus statement about advanced directives. So it's a document that helps your doctor and family be aware of the type of care that you want should you become seriously ill and you cannot communicate on your own. Again, this kind of also speaks to some of the challenges. We often expect that advanced directives are only needed if we're talking about limitations of care, but it can be really valuable to know for sure that a patient would want us to not have limitations on their care as well. So in either direction, I think it's important to make sure that we have those documented wishes of the patient. So an advanced directive, so what is that? I think the language around this, I think it's very confusing, so I'm hoping that this will provide some clarity today. But advanced directive is a pretty broad umbrella type term. So there is not one thing that is an advanced directive. Lots of different things that are tools to help us know what patients' wishes are. Those are all forms of or types of advanced directives. So we're going to talk specifically today about power of attorney, the living will, the most form. I mentioned the 5 wishes form up here. It is something that's available, but there's a fee associated with it. It's a much longer form and has a lot of narrative for patients to kind of provide insight into things that they would like to happen at the end of life. So it can be a nice tool, but it is institutionally expensive. So living will. So it specifies your healthcare wishes. That's the idea behind this document. And I'm going to pass some things around. This is a kind of a one-page example of what we have available here at U of L. So at the top where we can appoint a healthcare surrogate, and then here we just have 3 simple questions that are going to ask the patients about planning for the for end of life care. What are their wishes? What scope of treatment are they interested in having? So that's always available here at the institution. It does have to be notarized, but it's nice. One page kind of represents everything that a patient may need to clarify. Specifically, we often ask about tube feeds, CPR, mechanical ventilation, antibiotics, and the scenarios in which we would use those antibiotics, dialysis, organ and tissue donation, and then comfort care. When would that come into play, and when would that be of interest to the patient? It is reversible at any time. So if a patient's life and choices change at any time, this is something that we can discard and that we can certainly replace with a new document. So again, patients may elect care limitations. Patient may choose a very aggressive intervention. And either way, we should make sure that we're doing everything we can to document what those wishes are of the patient. With the, I'm sure we all deal with and struggle with increased prevalence of chronic illnesses, which limitate our ability to be able to express our wishes, especially dementia. So making sure that we get these things documented, that we've talked about these things with folks upstream of those illnesses when they can't really express their wishes and discuss those concerns with us is really important. Power of attorney is another type of advanced directive. The terminology around this can get very confusing as well. So sometimes we hear healthcare agent, healthcare proxy, healthcare surrogate, representative, attorney in fact, patient advocate. All of this terminology gets thrown around in kind of different templates. Maybe someone found something online, or there's a local attorney that they've used to try and draft something like this. But any of these terms, the idea is that they have a piece of paper that says who the person is. If they cannot express their own healthcare wishes, this is who you should talk to. And so any adult at any point in their healthcare life should consider having a document like this, because the unexpected can happen. And we want to make sure that we're prepared and we know what people's wishes and concerns are. It can be the power of attorney may be its own document. It may be combined with a living will. That is also another terminology issue and challenge when you're asking what documentation they may have to use here in the hospital when we're needing that in an urgent way, that they may be confused themselves about what they have. Often the folks that are giving them the most advice are attorneys, and we appreciate them if we don't love them for everything that they do. But at the same time, we also need to make sure that they've had input from a healthcare provider about what these documents are, which ones are important, and which are things that they need to make sure they have in place. It only takes effect, again, if the patient is unable to express their own wishes. So if at any time, as long as we're talking to a patient, they're able to communicate with us and express what their needs and wishes are at end of life, that's who we should be communicating with and talking with. But this document can speak for them when they can no longer communicate with us. And again, this is reversible at any time. So just because we have a power of attorney in place, that's a document that we can discard and that we can start fresh with something new if we need to. So the question of durable, what is that? We hear that terminology get thrown around. I have a durable power of attorney. I have a durable medical power of attorney. So essentially the term durable refers to the fact that it does continue with the patient even beyond their own competency or their own ability to communicate their wishes reliably. So just because they may have a durable financial power of attorney does not mean that they have a truly durable power of attorney for their healthcare decisions. So that's, again, important as we're asking questions and trying to get more information, helping patients understand what they need, what they have, and what the differences are. Often powers of attorney that are maybe durable for financial reasons may actually even specify that they do not apply to healthcare decisions. So that's another thing that we need to make sure that we have on board and that we have clarity from them and that we have a document that we can reliably use. And then here we all are probably familiar with our bright pink pieces of paper, our Kentucky Most and our Indiana Post form. What we're looking for in those are a little bit different than the other documents that we just talked about. So the Most form here in Kentucky is actually a doctor's order, and it's portable. So it travels with the patient whatever institution that they may be in. So this can be certainly a very important issue if we have a patient who's maybe had a change of code status while they're here in the hospital, and that maybe we want to make sure that travels with them to the nursing home or other institution where they may be going, where their needs may not be as clear. So that can be really important, again, just to make sure that we have that documented. It's nice and bright pink. It has to be on pink paper to kind of be an official Most or Post form. And it is state specific. So when we have patients that are going back to their nursing home in Indiana, we really need to make sure that we have both a Most and a Post completed, which can be kind of a challenge, just extra paperwork. And because it needs to be on the bright pink paper, it's often advisable to consider having them fill out more than one of those forms. It's kind of a pain, but it's pretty easy to do at the bedside in terms of once we have one that's perfect, then you can kind of help complete some of the check boxes and then continue to have the patient sign. It has to be signed by a physician to make sure that it is, again, an order of medical treatment. And I know that Dr. Furman has done a lot of work to make this part of our available here at the state, but the most post initiative is a national initiative. And so every state has some version of this wherever you may go and practice. And here in Kentucky, I know that we've sort of talked about potentially APPs or other folks being able to, at some point, help complete with these documents, but that's something that is in development. So for right now, it really does need to be a physician. Let's see. And then it is the type of document that's best for someone, we would say, in the last year of their life. Because this document is asking some very specific questions about exactly what people would want in end-of-life care. And so because it is a medical order, it is something that's going to be, that they're going to use in whatever setting that they're in. We want to make sure that that's as clear as possible, and this is a document that provides a lot of clarity. Some of these questions may be a little bit overwhelming or too specific, too abstract for folks that do not have an advanced or life-limiting illness. So just something to consider in who you're prioritizing filling out and completing paperwork with. And again, just like every other document we talked about, it is completely reversible. So we can tear it up at any time, and we can fill out a new one to make sure that the patient's current needs are being met and wishes. So the other form of advanced care planning that we do is when we put that DNR code status into our EHR, whatever that may be. There's, again, a lot of different terminology that's used depending on the type of institution where you are. So A&D is one I think we hear a little bit less and we're moving toward, but allow natural death rather than do not resuscitate. I've found that language to be helpful with patients sometimes, rather than the sense of that we're withholding care, restricting care, taking something away. It's the idea that we're allowing a natural process to occur, which, depending on their wishes, their healthcare needs, that may be the appropriate status for them, depending on each individual patient. So whenever we're talking about filling out these forms, the question of capacity always comes up. Can this patient reliably communicate to me what their wishes and needs are? Can I let them sign this form? Can I rely on what this form says? Am I going to wind up talking to a judge someday if I've let this person fill out this form? So Two ideas here that you guys may have heard of before, capacity and competency. So capacity is something that is a physician determination or healthcare provider determinant. Competency is a legal term, and so folks have to have appeared before a judge, have gone through an entire legal process to be declared competent or incompetent. And then quite often those folks are going to have someone like a state-appointed guardian or have a family member who's been appointed by the state to help provide legal or sort of material advocacy for them, to be the person making their decisions for them, as opposed to capacity, which is something that we can assess at the bedside. So the principles kind of assessing that is that a patient must be able to receive information. Obviously, if we're not conscious, that's not a possibility, but that they can receive information, that they can evaluate, deliberate, and mentally manipulate information, and that they can communicate a treatment preference. So those are kind of the three big determinants that we have to be assessing as we assess patients. And it needs to be in the context of the fact that we can see that they can understand, that they can use logic, and that they show internal consistency. Whatever the decision might be, if their opinion, thoughts are changing rapidly in short periods of time, that's certainly a cause of concern about whether or not this person has capacity to make these kind of healthcare decisions. It is task specific. So again, maybe we're talking about whether or not a patient's going to have surgery. Maybe we're talking about whether or not a patient is going to undergo some other kind of intervention. Maybe we're talking about code status. But different types of medical decisions are going to require different amount or different type of capacity. And then it is time specific. So when we're saying right now, this patient that has a dementia process is currently able and has capacity and is able to make these decisions for themselves, but we may understand that 2 years, 3 years, 4 years down the road that may not be true. And that's something that we can reassess at any time. So it's not that we've assessed that they have capacity, we're done forever. This is something that's going to be an ongoing process. So when to revisit advanced care planning. So anytime there's a new diagnosis, certainly anything that's going to affect the patient's prognosis or length of life, those are things that we need to be discussing with them, their advanced care planning. Change in like marital status. So I think one of the ones we often miss is if a patient is widowed, then that spouse was probably listed as their medical decision maker. And so if that person is not able to make that decision for them, we need to update those documents and help them with that process. And then about every 10 years. Certainly our healthcare wishes when we're 40 are different than when we're 80. So we need to be making sure that we're periodically revisiting that with our patients. So the cool thing about all of this is that it is something that we can bill for. I think rarely in medicine do we feel like good work that we do that's hard to do and Medicare reimbursement overlap. This is thankfully a place where that is true. So 2 CPT codes that we have, 99497, 99498. Both of those are the advanced care planning codes. So approximately up to 15 minutes of advanced care planning is something that we could conceivably do as a part of an E&M service that we wouldn't need to or wouldn't necessarily be able to bill. But when we're having a more extended conversation, when that conversation is going on, so we've crossed a 16-minute threshold, then we are able to bill for that. And so those first 30 minutes are up to that as that first code. Then once we've gone beyond that 46 minutes, then we're into an additional code time. So another 30 minutes. So that's just another example of the kind of examples of the time-based billing for that code. This became an official policy in 2016, that fiscal year. So there's no limit on how often advanced care planning can be reported for a given beneficiary for a given amount of time. And when the service is billed multiple times, it is one of those things that, there may be regulatory oversight and review, so that if we are billing this frequently, they're going to expect that something has happened, that we're having some sort of change, some document will be completed. But we actually aren't required to complete a specific document at all in this process of doing advanced care planning. So time requirements, we kind of went through that. What's nice is if you do, for some reason, have one of those visits or experiences here in the hospital where you are spending a whole lot of time with the patient, that you can actually bill for that. So again, for every 30-minute interval, you can add that 99498. So where can you bill for advanced care planning? Well, the answer really is everywhere. So from your clinic to the bedside here at the hospital, if you're making a nursing home visit, if you're doing a home visit with the patient, any of those locations. There's no location restriction on where you can bill for that. And again, it can be combined with your regular E&M code. So the visit that you're doing here in the hospital, again, that E&M service, you can combine advanced care planning codes with that. So who can bill? There's no specialty limitation. You don't have to do a fellowship in hospice and palliative care to be able to bill for advanced care planning. It should be the time-based billing is the time that's spent face-to-face by an attending physician. That doesn't mean that the time that residents and fellows and maybe medical students spend doing this kind of discussion is irrelevant. It's going to help lead to the conversations that we have, but it is a face-to-face time when you all become attendings that it's going to be the issue. Let's see. So there is also some vague language here in terms of what Medicare has listed for us in terms of who can bill. Other staff under the order and medical management of the beneficiary's treating physician. So there is some leeway as well in terms of who can participate in this. Anyone who's billing Medicare is someone who potentially could participate in this. In terms of the guidelines for documentation, so what we have to demonstrate and what we have to show, it must be voluntary. So the Part B deductible and coinsurance can apply for this unless it's the annual wellness visit, and the advanced care planning is included as part of that. The reason that this kind of matters is that we have to make sure that we've informed our patient that this is a potential thing that they could receive a bill for, though that's generally a fairly small copayment for the patient, but something that we want to make sure that we're kind of leaving a good sense of informed consent with the patient as we have these conversations and we're documenting and we're billing. So what else must be included in the documentation? Obviously that it's voluntary. An account of the discussion, so what we talked about together, explanation of advanced directives, if a form was completed, but again, no form has to be completed to bill for advanced care planning, who was present during the time that we had this conversation, the time spent on the face-to-face encounter in minutes, so not necessarily time in, time out. And then there's no specific diagnosis that's required. So it's not like we can only bill for advanced care planning in dementia or metastatic cancer. But whatever the diagnosis is that we had this discussion about, that should be the diagnosis that we use for reference. So metastatic cancer would be an option. And then, so just kind of important things to keep in mind is that if we do have a time-based billing code, so if we are billing on time rather than sort of the other parameters of that visit and that E&M service, then we can't include the time that we spent for billing the primary visit with the advanced care planning code. So if we spent 30 minutes talking to the patient about their diabetes and hypertension, and we spent another 30 minutes talking with them about their advanced care planning, then those are the two separate time frames that we're going to have to use. So this is just another quick case example of the kind of interaction that we probably all have every single day here at the hospital. 75-year-old man who presented to this admission, shortness of breath, chest pain, concerning for pneumonia, and then eventual identification of a mass and biopsy confirmed small cell lung cancer. So during his admission, he has increasing O2 requirements. Since his admission 2 days ago, you've not seen any visitors since that time, but you've heard nursing say that his wife plans to come when she can arrange transportation. She doesn't drive in town. We've probably all heard that. You decide that you want to have a family meeting, and so you choose to explain the concern about his diagnosis, forms that are available, and he states that he would like to appoint his wife as a healthcare surrogate, but doesn't necessarily want to complete any advanced care planning documents. 2 days later, he's had a chance to kind of think more about this issue, and so he's interested in completing a MOST form, and that's something that you do together. So this is just kind of an example of the documentation that would be needed to document that you did this advanced care planning. Not too cumbersome, a nice little narrative about what you guys talked about, 4 or 5 sentences total, who was present, who participated in the conversation, and the outcome of that decision. And then as we come into the family meeting, so the first time we spent 90 minutes in the room doing this advanced care planning. The second time we actually signed the MOST form, we spent 30 minutes going through the form, getting it completed. So the initial, we would bill the 99497, and we can only bill one of the 99498 because we didn't cross into that, greater than 46 minutes. And then signing the MOST form, we can do another advanced care planning code there as well. So just to kind of show you guys, I know when I was a resident, I didn't care about RVUs at all, and I thought that was dumb, and I hated that everybody wasted my time talking about it on the rare occasions in which it did come up. But it turns out it's really important. So I did outpatient family medicine for 5 years, and I was living and dying by my RVUs every year. Would I be able to take that vacation or not? So this is just kind of an example to keep in mind. So for a level 4 office visit, if you are in a clinic setting, you get about 1.1 RVUs for that. For the advanced care planning codes, you actually get 1.5 RVUs just for that initial advanced care planning code, and then 1.4 for additional time that's spent after that. So that's according for Center for Medicare Services. So this is just a little thought problem kind of on the other side of the slide. So just looking up some numbers, this is on the moderate end of the spectrum, but an average internal medicine physician, is asked to generate between 4,600 and 4,900 RVUs annually. And so if that's true, if we would imagine that 25% of those RVUs might represent, average level 4 visit, that 1.1 RVUs, it would take us approximately 1,045 visits to be able to complete that many RVUs. If we were completing advanced care planning with that level 4 visit, that's 2.6 RVUs for each of those events. And so it actually would reduce our number of visits to 442 to be able to achieve that many RVUs. So that's a difference of 603 visits. So when we're talking about efficiency of our time and our billing, this is something that can make a huge difference. in terms of the way we work smarter and not work harder. So this is advice that may be practical for you in a few years, and you may never use this information ever again, but it is something that can be helpful, and it also helps patients. So it's a good thing, and it helps patients, it helps you, just something to keep in mind. So a few kind of points of advice on having these kind of conversations. So when we're talking about advanced care planning, we're trying to push that upstream and have those conversations earlier and earlier with patients rather than waiting till we're in emergency settings and situations and in a difficult time. So it's good to introduce the idea of advanced care planning as something that we do with all patients, regardless of their healthcare situation currently. Sometimes that can help make the conversation just a little bit more open and them a little bit more receptive. So you can make Medicare both the good guy and the bad guy when you're having these conversations. So Medicare is offering essentially them, covered service to provide planning for end of life or their future of their healthcare needs. So that's something to keep in mind. And then also, especially for our wellness visits, Medicare is telling us we kind of have to talk about this. So depending on the situation, you can kind of blame it all on Medicare. Research also is very confirmatory that patients want to have these conversations. They're actually more frustrated by being in healthcare situations in which they are really uninformed or underinformed about what their options are, what their needs are, what their prognosis is, than being in situations where someone is, forcing them or initiating a conversation about advanced care planning. So the research is pretty clear that they want more of this from us, and that we really should be trying to push these conversations and more to have them just in general, but then also upstream in their healthcare when they're healthier. It's important to remind folks that no choice is still a choice. So if folks do not complete an advanced directive, what are we going to do? We're going to assume that they want the full scope of treatment that we can pretty much imagine for them. So that's something that's important to keep in mind, is that if patients are not interested in that level of treatment, or depending on their situation, some limitation in that, then we really need to make sure we get that on paper. But even if they have decided not to put anything on paper, we still have a plan of care for them, and they need to know what that plan of care is. So we always want to strive for honesty and clarity when we're talking with patients. When I first started fellowship, I used the term passed a lot, right? Mr. Jones passed, and so I was encouraged to be frank and to use the real words. So the patient died, because we want to make sure that that's an example, but we want to make sure that we're being clear with patients. We're not leaving guessing room, or they know what's going on. And we also want to make sure that we're being as free of medical jargon as possible, especially when we get to completing advanced directives and there's so much terminology that can be so vague and confusing and disconcerting to patients. We want to make sure that we're providing clarity. So don't be afraid to call your friendly hospice and palliative care fellows, or your palliative care service in your hospital, or your social worker, or your chaplain, all of which have a lot of skills in treating and being able to complete these documents. Don't ever let someone pin you down to an exact prognosis. So when we are providing prognosis to families and patients, we always provide ranges, hours to days, days to weeks, weeks to months. We're never saying, 37 hours and 29 minutes. It's a recipe for disaster and for failure, because we'll be wrong, and then we've sort of lost that credibility with the patient or the family, and going forward and making decisions and plans becomes more challenging. You want to clarify the question that you get from a patient, if it's vague or broad. So we just want to make sure that you understand what the patient really is asking, as opposed to sometimes we are ready to hear the question we're afraid of, as opposed to hearing what the patient really is asking us. So they may not be asking for an exact prognosis. They may not be asking us to see the future for them. They may be asking a little bit more just for clarification and understanding about what their actual diagnosis is. And it's always okay to say that we don't know, that we need more information, that we need more time to get this right, because it's important to get right for them. So that's all I have. We'll pass these forms around for everybody so you can walk away with your most and your post form and enjoy it and love it. And hopefully fill it out with the patient. But if anybody has any questions, I'm more than happy to answer.